Personality disorders in the elderly to begin with are very difficult to diagnose and furthermore very difficult to treat. And there are a number of different reasons for this. For starters, the presentation in elderly tend to be rather complex. It's not something that's uh, what we would call remotely straightforward. And frequently there's a significant lack of a sufficient database upon which to make one's determination and diagnosis. The diagnostic and intervention methods are really rather rudimentary, particularly in the elderly. There's um, talk about get two people in a room and have three opinions. That's exactly what we see when it comes to diagnosing personality disorders in the elderly. There's a definite lack of clinical consensus, and there's furthermore a lack of evidence-based practice guidelines. So we're really kind of um, flying in the dark here totally when it comes to diagnosing personality disorders in the elderly. And there are many different reasons for that. Among the more common reasons, the patients that are seen, geriatric age patients, present with a polymorphous psychiatric symptoms, and this is often intermingled with very vague physical complaints that are really hard to pin down into any one particular category, oftentimes seen in the face of very poorly managed medical problems. I know this is something that we encounter all the time in the primary care patients that are seen in Suite B, where I work. Add to the mix some cognitive soft signs, and if that weren't enough, add into the whole mix the interpersonal and family conflicts that are frequently part of the overall picture. The bottom line is it's really hard to put your finger on the nail and come up with an accurate picture when it comes to diagnosing personality disorders in the elderly. Let's go back a step or two and come up with some definitions here. What is a personality trait? And the best definition that I found was an enduring pattern or enduring patterns of perceiving, relating to, and thinking about the environment and oneself, exhibited in a wide range of social and personal contexts. So that's, I think, a pretty good definition for personality traits. But personality traits in and of themselves do not make for a disorder. All of us possess number of personality traits. Many of them are adaptive. However, they do not constitute a personality disorder. So let's talk about a definition for personality disorders. And that occurs when personality traits are inflexible and maladaptive and cause either significant functional impairment or subjective distress, such that they constitute a personality or constitute personality disorders. So with that background, let's move forward and just a quick review from DSM, the different clusters of personality disorders, the autocentric cluster A, which is typically comprised of the schizoid, schizotypal, and paranoid personality disorder types, of the cluster B, the dramatic/emotional personality disorders, characterized mostly by the histrionic, borderline, narcissistic, and antisocial personality disorders, and cluster C, which refer, generally speaking, to the anxious and fearful group or cluster of personality disorders exemplified by the dependent, avoidant, and obsessive compulsive personality disorder types. So with that in mind, what kind of diagnostic tools are available to help to nail down as best we can personality disorders in an elderly population? Well, there are a number of them. First of all, the self-report measures. And you would think that that would be something very useful, but the problem with that is that oftentimes it may be hampered on the part of the patient by lack of recognition of ego dystonic behaviors on the part of the patient. The use of structured interviews, something which is frequently used in other areas, but those two are oftentimes vulnerable to clinician biases and judgment, as well as mass confusion with coexisting mood states. So again, we're left to trying to pin down a very fleeting and moving target in many, many, many instances. Now, it gets a little bit more complicated than that in terms of diagnostic factors, because we have to really try to capture as best we can the entire longitudinal history of maladaptive and deviant behavior. And getting that kind of longitudinal history is fraught with problems in a number of different respects, and also the patterns of dysfunctional interpersonal relationships over many, many years and decades. It becomes a tremendous mishmash and something which is very, very difficult to pin down a fleeting and moving target as such. So we're going to try the best that we can and talk about some of the normal personality myths. And there are a couple that I chose to mention here, and we'll go through some of these a little bit. And these reflect oftentimes the biases on the part of many clinicians working with geriatric age patients, the downward drift stereotype. And that's the belief that most adults become dependent, stubborn, hypochondriacal, regressive, childlike in their behavior as they age. And that's really in contrast to the basic stability of personality as seen or as believed to occur as people age. And it's much more an opinion and myth as opposed to something which is factual in nature. Brittle adaptation, and that's the belief that age-associated physical frailty coincides with increased frailty of personalities. Again, absolutely no evidence whatsoever in regard to brittle adaptation. And finally, the lack of continued developmental development, or in other words, personality stagnation, or what I've been accused of being too old to change, and coping styles become increasingly rigid and inflexible. Well, that may be a convenient excuse, but there's absolutely no evidence whatsoever to support the notion of personality stagnation. Now, it's not just coming from the part of the patient, but there are also many additional clinician-related factors. The assumption that personality disorders are rare in later life, and there's absolutely no evidence that they are indeed rare. The distinguishing between personality disorders and various medical and psychiatric disorders, particularly chronic axis 1 disorders, it becomes really very, very difficult to pin down patients and come up with a really good diagnostic picture of personality disorders that they may exist in their later years. Now, there are many different problems with the DSM criteria. Inherent in the DSM criteria, they fail to capture age-related manifestations of personality disorders. What exactly are the age-related manifestations of personality disorders? The problem of applying impairment of social occupational functioning criteria to the elderly when oftentimes they're not in those particular realms to begin with. The lack of reliability and validity of assessment tools that are largely designed for younger adults. And furthermore, the lack of reliability when it comes to obtaining an accurate longitudinal history, not only from patients, but from family members as well. So those are some of the issues and problems with the DSM criteria for personality disorders as they relate to a geriatric population. How common are personality disorders? Well, overall, they're thought to occur with an overall prevalence of about 10% in adults over the age of 50. However, when it comes to geriatric age patients, there's some discrepancy. There's a range, if you will. Prevalence rates for non-clinical elderly samples do range from approximately 6% to 13%, as opposed to 9 to 13.5% in mixed age samples. So exactly what it is probably in the same range, but we don't know definitively that it's going to be, once you get into the upper years of one's life, exactly what the true prevalence of personality disorders may be in that population. a number of questions that do come up. What is the natural history of personality disorders? Nobody really knows. Do the manifestations of personality disorders change? Nobody knows. Does the severity of personality disorders change? And the simple, clear-cut answer to all of this is it's really unknown. So with that in mind, what are some of the further diagnostic challenges in trying to pin down this moving target? Well, distinguishing axis 2 disorders from pre-existing or persisting axis 1 disorders, detecting personality disorders in the complex of a really difficult, complex picture of medical, psychiatric, psychosocial, and behavioral problems. Again, trying to find the needle in the haystack, distinguishing personality disorders from personality change that occurs secondary to medical conditions that are not at all uncommon in the elderly population. For example, distinguishing and teasing out a borderline personality disorder versus frontal temporal dementia. Very, very difficult to make that distinction. And finally, distinguishing personality disorders from non-volitional disturbed behavior, which is frequently part of the picture seen with moderate dementia. One more, and that's distinguishing personality disorders from chronic regressive behavior in the context of physical illness or changes in psychosocial environment. So much changes in those realms with the elderly that it's really hard to keep your attention focused on personality disorders and how they may be distinguished and teased out from those changes that occur in the elderly population. Some recommendations for assessment. Well, I think it's nonetheless very important to make an effort to screen for personality disorders, given that there's probably some degree, some prevalence of elderly personality disorders given the younger population. And again, this is somewhat of an assumption, the assumption that at least some of that does carry forward into a geriatric population, using the general criteria, the overall criteria seen in DSM as an initial guide. I'm sorry, notwithstanding the admission that there is a lack of valid criteria in the elderly, and to sort out, to the extent possible, manifestations of personality disorders from persisting axis 1 disorders, as well as personality changes that result from changing medical conditions in the elderly population. And finally, the view that personality disorders in the elderly are really have to be viewed in the context of an ever-changing psychosocial environment for so many of the patients that we take care of as they get older. Sometimes the psychosocial picture can change not only by the year, but by the month, and sometimes even more frequently than that. And I think the COVID pandemic is a perfect case in point in that so many changes occurred in the psychosocial realm for so many people, and the elderly were caught up in that massive wave of psychosocial environment change that many of us experienced as well over the past year and change. What are some of the basic treatment principles if one suspects a personality disorder in the elderly? The first and most basic, and this is nothing too complex, is the need to maintain a consistent therapeutic alliance, not only with the patient, but with the family members and caretakers and everyone in that the family unit involved with the patient. It is of critical importance to ensure for the safety of the patient, anticipate crises as they occur and be prepared to manage them. And crises can occur not only related to personality disorders of the elderly, but of course, the ever-changing medical picture and psychosocial pictures of the patients, and treat really in the context of an overall treatment team. It's really very difficult to treat as a single or individual practitioner because there are different people on the treatment team who may see and be witness to different aspects of the patient and the problems that present with the patient. And finally, the judicious use of medication, particularly when There are situations of behavioral issues that require the standard non-medication treatment approaches certainly don't work. So let's just focus for a little bit on the role of medication, when to judiciously use medication to maximize treatment of comorbid psychiatric conditions to the extent that they're known and recognized and can be treated, to reduce the intensity and frequency of maladaptive behaviors, and to the extent possible to avoid behavioral crises. So the bottom line here is that there's no absolute role of medication, but they can be useful as an adjunct when treating patients with personality disorders in the elderly. Some of the pitfalls, the abusive patterns of use on behalf of many patients, and it's not just limited to patients themselves, but oftentimes when they're living with family members as well, and the family member has control over the medication, that can be an opportunity for an abusive use of medication as well. Overdoses on the part of patients, as well as suicidal gestures, which frequently are cries for help. The unsupervised use of medication in elderly patients with personality disorders. And finally, and this is really something important to bear in mind, as many of the patients do present with cognitive impairment, the use of medication can cause serious damage. Patients who forgot that they took their medication and take the medication multiple times over the course of a given day. It's really important when medication is used to have an ironclad system of medication management for these patients. One thing that I've always done, not just with elderly patients, but with all patients that I've taken care of, and I'm a firm believer in pill counts to the extent that we can keep a real good handle on medication use by patients. And that is the end of the story, the bottom line. And just to summarize very quickly, it is a difficult and moving target that when focusing in on personality disorders in the elderly, no definitive criteria that we can utilize, a lack of research, reliable, valid research to guide us. So in most respects, unfortunately, we're shooting in the dark, but nonetheless, working from the part of the providers as part of a unified treatment team and working with all resources, not just the patient, but everyone in the patient's environment, can help guide the patient and minimize crises and help the patient deal with the challenges that they face as they grow older. So at this point, let's open the floor.